So, we're still in chapter 28. This is the latter half of it. The first part of this chapter, in it, was healthcare-associated infections, followed by microbiological and immunological testing, including antibiotic testing. In this part of the chapter, we're going to look at vaccinations and then antibiotics. So let's talk about prevention of disease and treatment. One way for a population to be protected against a disease is for people in the population to get the particular disease we are talking about and become immune. Not that they'll be immune for years or a lifetime. It may be a shorter term immunity, or it may be immunity over many years or even a lifetime. Depends on the disease. There are hazards in getting immunity for a population that way because a lot of people are going to get very ill and die. So it would be nice to be able to control the immunity in a population in a better way where we don't lose as many people or they become very ill, and maybe they don't die, but they have a lot of very bad side effects that may last for a lifetime, like deafness or kidney damage or changes in brain function as a result of the disease. So let me jump down to immunization. If we give the people in the group a vaccine using the particular antigen that is associated with the infectious disease, then we have the controlled immune response in the population that will protect them. And without the bad effects of potential deaths from getting the disease or the side effects of the disease. We'll talk more about immunization in just a minute. Another thing I want to point out is treating somebody after they've already been exposed. Immunization is what you want before you've been exposed. The only vaccine that I can think of that you receive after you have already come in contact with the infectious agent is rabies. And the only reason that works like that is that rabies has a long incubation period while the virus moves all the way up to the brain. So you can immunize after exposure, but that's not the usual case. So if you have been exposed already to an infectious agent like hepatitis A virus, and it's too late for vaccination because the immune response from the vaccination won't occur fast enough to protect you against the virus, it might be helpful for us to give you pre-made immunity, that is, immunity from another source. Maybe that immune response comes from another person in the form of antibody, or maybe we get the antibody from an animal that has been exposed to that virus, like a horse. Horses have a large blood volume. They're relatively docile, so they have been used to make antibody to infectious agents for a long period of time. Before we leave this page, I want you to notice that graph down there at the bottom. The red line is showing you the active acquired immunity produced by immunization your own immune system making the immune response after exposure to the antigen or the infectious agent. So you see the primary immune response at the far left bottom, and then you've got two secondary immune responses. Then the blue line is showing you what happens when you give passive immunity. So, again, maybe you've been exposed to hepatitis A, you get gamma globulin injections. Gamma globulins are antibodies, and you have a short-term protection. It's an immediate protection because the antibodies are already made, but notice that the antibody concentration goes down. Those are not your own antibodies. They do not stay long-term in your body, only some weeks. Whereas with the active acquired immunity, you get adaptation. Your immune system, exposed many times, will give you a stronger response, and that response lasts longer. There's no way we can talk about immunization without talking about smallpox. I don't really want to get into smallpox that much, but it's a perfect example of a disease, maybe the only disease, that has ever been controlled by a vaccine, eradicated because of a vaccine. So let's go back in time to, oops, I have on there the wrong date. I did not mean to put the Chinese 2000 AD. That was pretty recent. I meant to put that much earlier. Sorry, my numbers are wrong there. So we're probably, the Chinese and the Turks are known to have used smallpox vaccine to vaccinate their populations. Certainly the Turks in the 1500s, Chinese goes maybe back to 1000 AD. That is actually what I meant to put instead of 2000 there. However, their procedure was different than the ones we used to use for smallpox. Now, smallpox vaccination has not been done for the general population since the 1970s, although it's been done for the military long after that, I think even now. Another difference between the way the Chinese and the Turks did vaccination is they actually use the smallpox vaccine. You see a little girl there with the lesions of smallpox. It had a very high death rate, maybe upwards of 60%. And even if you survived it, by the way, a lot of people became blind, organ damage, and so on, so there were a lot of side effects. But if you survived, one of the effects was that you had scars all over your body. So when these lesions of this little girl go away, she will have scars where each of those lesions are, even if she lives. So what the Chinese would do is they would take some of the material from these lesions, they crust up, and you can see what it looks like on the other two pictures. Down at the bottom, there's a picture of a scar from a smallpox vaccine over time, and then the picture above shows a child over a period of about 14 days developing the typical lesions and then the scabs from actual smallpox. So back to the Chinese, they would take the material from the scab, grind it up to make a powder, and they may have inhaled it via nostrils and immunized themselves that way, or scratched it into the skin, because there have been tools found that appear to be used to make a scratch into the skin. Now, the downside of giving an immunization like this is that some people actually died of the immunization. Now, remember, the Chinese knew nothing about vaccination, but they did know that once you got smallpox, you were immune for a lifetime. In fact, in a lot of cultures, those people that got better from smallpox had to take care of the people that had smallpox because they knew that those people would not get it again. So The smallpox vaccine, by the way, that procedure is called variolation, the procedure of immunizing against smallpox using the actual smallpox virus. The name of the smallpox virus is variola. Now, let's fast forward to the 1700s. And in the 1700s, there was a woman that was living in Istanbul with her husband, who was a British diplomat. Her name was Lady Montagu. You see a picture of her here. She was well-bred, had money, had resources, and because they lived in Turkey, she had seen the procedure of this variolation done. And the Turks had been doing this for a very long time, and it was well known that you would be immune as a result of this procedure of becoming immunized. And again, remember, they know no immunology or microbiology at the time. So she got her 5-year-old son immunized this way with no detriment to him, and she wrote back to friends in England, where she was from, about the procedure. She was a big proponent of it. When her family moved back to England, she did the same thing, trying to talk people into this procedure. She had her 3-year-old daughter immunized this way. And it slowly began to take hold in England. And in the latter 1700s, when the Brits were in what would become the United States, they were immunized in a similar fashion, and eventually our troops, the Patriots, during the Revolutionary War, also got the same procedure done, because they realized that if the troops were dying or ill from smallpox, they would not be able to fend off British troops very well. Now, let's go to another procedure, not called variolation, but the name would be vaccination. This is using a different virus. The father of vaccinology, we will call it, which actually is a word, is Dr. Edward Jenner. You see his picture there at the bottom middle area. We're in the 1700s. He's a country doctor in England, and he understands that milkmaids, the women that get milk, draw milk from the teats of cows, udders, get a minor infection on their hands, but they do not ever seem to get smallpox. He had recorded this. And so he decided that he would take pus from the lesion of a woman who had this on her fingers and inoculate it into a little boy, which he did. And that boy was protected against smallpox. I should say smallpox was rampant during this period. It wasn't uncommon. Interestingly enough, these milkmaids had very fair skin on their faces, had no lesions from smallpox. Remember, and by the way, smallpox lesions were very abundant on the upper torso and the face. So it was noticed that these milkmaids did not have the lesions. Only this little rash on their hands. It turns out that that virus was called the cowpox virus eventually, and its name was vaccinia. Vacca, as in cow. His idea, as I already mentioned, was to take material from the lesion and scratch it into the skin of a person to vaccinate them. And the picture that you see up at the top is showing you a cow upside down being held down. They've made very small scratches into the abdomen after they shaved the hair off of the animal, and it produces this mass of lesion material, and then they would scrape it off and make it a powder and use that to vaccinate people. We used a variation of this vaccination procedure even up until the 1970s with a few variations. Interestingly enough, it was not the same virus. Somewhere back in the 1930s, there seemed to be a change in the virus, and it's not really known where the virus came from for the vaccination that I got, for example, as a child. It was not the original cowpox virus, or it may have been another animal that it came from. Some people think that it has to do with a virus from a horse, but there's not a whole lot of recorded data on it. Other people important in vaccination, the other big person would be Louis Pasteur, who came up with the rabies vaccine using rabbit spinal cords to dry dry over a period of time. It weakened the virus. Now remember, we are in the latter 1800s, and microbiology is still a baby science, and virology is not even known yet. So he was doing this rather blindly. Remember, rabies is a virus. But he had to do something with his work, his research, because he was presented with a boy that had been bitten multiple times by rabid dogs. Joseph Meister, he's the boy that you see in the picture down at the bottom right. And he used his dried spinal cords. And he started with the oldest spinal cords, giving injections over about a 2-week period, going from the oldest cords to the freshest cords. So the virus was becoming more potent over time, and in fact it did work, and Joseph Meister did not get rabies. And again, we used a variation of that vaccine for rabies for a very long time, although we do not now. That weakening of the virus by drying out, in this case, is called attenuation. Attenuation comes up in vaccinology a lot, because if you're using an active virus or a live bacterium in your vaccine, it needs to be weakened so you do not produce the disease in the people who've been vaccinated. The other person I want to mention is Robert Koch, not because he developed a vaccine. He was working on a tuberculosis vaccine, which would have been wonderful, but it just did not work, and so I just mentioned him because he was unsuccessful. These are some of the things that you probably think of associated with vaccines. If you do any research on the internet, you come up with a whole lot of conspiracy theories about them and unproven information that I don't really want to get into here because we don't have enough time. There are some concerns. There may be some side effects. For example, when you get a tetanus vaccine, your arm hurts for a couple of days. Part of it is because there may be other things in the vaccine which are called adjuvants, and very often aluminum or some other material might be added, sometimes soap, and it helps to enhance the immune response to the antigen. Relatively minor side effects. You're tired for a couple of days, you have a fever, soreness, something like that. There may be more severe side effects. Every once in a while, there may be a person who is vaccinated and has an allergic reaction, a severe allergic reaction, and they go into anaphylactic shock. I don't really want to get into the autism connection here because there really doesn't seem to be one. There have been studies and studies and studies and studies that do not show a vaccine, so I'll just leave it there. Types of materials that are in vaccines. I've mentioned attenuated live. There are also vaccines that have killed bacteria or totally inactivated viruses. Examples of killed or bacteria or inactivated viruses might be the flu vaccine, like Fluzone, that you get a shot of, or in the case of a killed bacterial vaccine, something like typhoid fever vaccine. For attenuated live, the MMR, measles, mumps, rubella, and the chickenpox, because now varicella or chickenpox has been added to the MMR. Those are 4 different viruses, all attenuated. They are active, but they are weakened. Then we go to the toxoid vaccines. If you look down the list here, somewhere down around tetanus, you see toxoid. Remember, this is Clostridium tetani. It produces an exotoxin excreted by the cell. It can be manipulated chemically so into a form that is no longer toxic, but it is still immunogenic, and that is called a toxoid. Another example of a toxoid vaccine would be for diphtheria. Subunit vaccine. This is a piece of the microorganism, not a whole organism. If you look at meningitis right about in the middle here, you see nature of the material is polysaccharide. This is the capsular material of Neisseria meningitidis that surrounds the cell. Only a piece of the microorganism. There should not be much of a downside to this type of vaccine. There's no way to get the disease. DNA vaccines. Exactly what they sound like. And let me show you on this picture. We've made, up here at the top at about 1 o'clock, we have a plasmid that comes from a bacterium. And inserted in the plasmid is a gene for perhaps a protein of an infectious agent, like maybe a particular HIV protein that it makes. Not the whole genome, just a protein, a gene that makes codes for that protein. So we have made an engineered plasmid. We then use that in a syringe, inject it into, for example, an arm, into the muscle, deltoid muscle. The cells will produce the protein, which you see as little red wiggly things here, from the gene. Those proteins go out into your body, get phagocytosed by APC cells. You see the macrophage, you see a B cell over here, which identify these as foreign proteins. That then turns on humoral immunity and cellular immunity. You can understand why this is called a DNA vaccine. There are also variations of this, RNA vaccines. They're relatively new. So what do you want in a good vaccine? Here's a list of things. And so I will go on from this. And let us totally change directions and talk about drugs for treating infectious diseases. We don't really have time to go into the history here. You can see that the history of antimicrobial agents is relatively new, 20th century. I do want to point out that a malarial medication, quinine, was discovered in the 1600s. Actually, it was developed by the Indians in South America, but it was given to the Spanish conquerors to help them resist malaria. So that's the earliest antimicrobial. But the rest of them, as you can see, are 20th century. So who are the big producers? Who makes an antibiotic? Bacteria and fungi. You can see two, and by the way, there are a lot more organisms that make antibiotics than these 4, but these are the big 4 workhorses that make antibiotics. Streptomyces genus and its relatives, probably the most important because it makes the widest variety of antibiotics. Of the fungi, Penicillium mold makes penicillin, Cephalosporium makes the cephalosporins, and Bacillus, the other bacterium listed here, makes some things like bacitracin. I've used the word antibiotic without defining it, so let me do that. An antibiotic is an antimicrobial made by a microorganism against another microorganism. You can understand the benefit of this to the microorganism. It kills off its competition. A lot of the antibiotics that we use, though, have originated as antibiotics but have been manipulated in a laboratory in a chemical fashion to change them a little bit. And those are called semi-synthetic drugs. They originated as true antibiotics, but then were chemically changed. And then the third category are the true synthetic drugs that are made from scratch in a laboratory and did not appear in nature at all. The view down here at the bottom shows you Serratia marcescens, the red-pink colony organism, growing with Micrococcus luteus, the small yellow one, and you can see there is a chemical being produced by Serratia around the colonies that is inhibiting the other organism. So you don't really think of Serratia as being a big antibiotic producer, but I wanted to point out again that a lot of microorganisms make these antimicrobials. So what are you looking for in a good drug? Either synthetic, semi-synthetic, or a true antibiotic. Most of these are self-explanatory. Let me start over here up at the top at a high therapeutic index. This is a ratio between toxic dosage to therapeutic dosage. Toxic dosage is the dose of the drug that can produce side effects in the host. Therapeutic dose is the amount needed to get rid of the infection. You would like there to be a large gap between the two doses. If these two doses are close together, that is, the dose that you need to get rid of the infection is about the same as the dose that's going to give you side effects, that is a problem, because if you're going to make the person seriously ill from the drug to the extent that the side effects might even be worse than the infection, you have not done them any great advantage. Another one that would be important to think about would be achievable in body fluids. The picture that you see of the graph down at the bottom is showing you penicillin given 3 different ways, and you can see that you get the greatest concentration of penicillin by giving IV, whereas if you give intramuscular, that amount that finally ends up in blood is going to be lower. So you have to think about that also. Drug interactions, not just maybe 2 antibiotics that are given. Sometimes they work together and sometimes they do not work together and may even work against each other, but also drug interactions between the antibiotic or the synthetic agent, whatever you're giving, and some other drug that the person is taking for some other reason. We'll talk about some of these other things more coming up in the future pages in the PowerPoint. So here's a look at 3 things you have to consider. When you give an antibiotic or one of these other drugs, you're going to affect normal flora.
Wait.
Remember, normal flora are good for
That's
you.
not possible.
So destroying them in large numbers creates a problem. It removes all of the benefits of those normal flora, but in addition to that, it opens up a lot of niches in the body that may allow organisms that were checked in numbers to now overgrow. And that's a problem. You'll see examples of that coming up. Another problem I don't already talked about in the immunology chapter is allergic reactions. Something like about 300 people a year in the United States die of allergic reactions from getting a penicillin injection. And that doesn't necessarily always have to be the outcome, but you can have very severe allergic reactions to these injected drugs. The main thing I want to mention on this page is toxicity. So you see a whole list of side effects here, some of them relatively minor, like maybe diarrhea, and some of them extremely dangerous, like kidney failure, damage to the liver, bone marrow damage, which means you can't make red cells, white cells, platelets for clotting. There can be neurological damage, so we can go from minor side effects to extremely major, life-threatening side effects. Spectrum of action. Narrow spectrum versus broad spectrum. Pen-G, plain old penicillin G, the one that you get by injection, usually in the buttocks, is a narrow spectrum antibiotic. It is mainly used against gram-positives like Staphylococcus, Streptococcus, very good against something like anthrax. Those are all gram-positives. Not used very much for gram-negatives. The reason has to do with cell wall. That's the kill location where the organism is affected by penicillin. It blocks the synthesis of peptidoglycan, and gram-positives have a very thick PG, peptidoglycan layer, and that antibiotic does a lot of damage, whereas gram-negatives have a wall of PG, very little of it, but it's overlaid by a lipopolysaccharide, and that overlaying lipopolysaccharide, which is a fat lipid, blocks some of the entry of the penicillin. The penicillin cannot get to the PG, and that's what makes Pen-G a narrow spectrum drug. On the other hand, something like a ciprofloxacin, or people call it Cipro, is a broad spectrum, and it's good against gram-positive bacteria and gram-negative bacteria. Each one of these has an advantage. Narrow spectrum drugs hit a specific type group of organism. Therefore, you get less pressure on other microorganisms that might become resistant from being exposed to the drug. If the drug does not affect them, you're not putting selective pressure on them to change, to adapt. The advantage of a broad spectrum drug is if you don't know what the cause of the infection is, you don't have that information yet, it might be good to start them out on a broad spectrum drug, and then you can fall back to a narrow spectrum. Narrow spectrum, again, is going to do less damage to normal flora, and it's going to put less selective pressure for mutations and changes in microorganisms that would provide them with resistance to the drug. And here's just a look at how they fall. I mentioned Pen-G, but I could have also mentioned, let me go back over here, it is not on here, yeah it is, isoniazid, which is way over here at the top left, is used specifically for Mycobacterium, particularly Mycobacterium tuberculosis. It's one of the drugs used for it. It's not really used for anything else. That's very narrow spectrum. I've already introduced you to one of the mechanisms of action for some of the antibiotics. So if you look over here at the top left under cell wall synthesis, I just was talking about peptidoglycan. Here are some of the drugs that work that way. So you see penicillins and cephalosporins here. If you go down to the bottom left to cytoplasmic membrane structure, these are drugs that impact the selective permeability of the cell membrane. The drug goes through the cell wall and then somehow changes the cell membrane, which controls transport of materials in and out of the cell and can cause disruption of cell integrity. In between cell wall synthesis mechanism and cytoplasmic membrane structure mechanisms, you see folic acid metabolism. So something like these sulfa drugs are called metabolic analogs. They block the production of folic acid. Folic acid is produced by bacteria from a precursor, and the sulfa drugs have a similar chemical structure to that precursor. The precursor is called PABA, para-aminobenzoic acid, and substitute for the PABA. So the cell picks up the sulfa drug inadvertently, trying to make folic acid, and of course it cannot make folic acid because it is the wrong molecule. So that's a metabolic analog. It's blocking a metabolic pathway. Now, up at the top, you see mechanisms involving DNA replication and RNA production. So you've got some drugs up here. There's ciprofloxacin, I mentioned earlier, which blocks the bacterial unwinding of DNA so that it can replicate and divide into daughter cells. And over on the far right, in fact the entire whole right side, are the drugs that act as protein synthesis inhibitors. There are many steps in protein synthesis. Remember that the mRNA has to attach on to the ribosomes, the tRNA has to come in and attach at the binding site to the mRNA. The tRNA has an amino acid. The amino acids attach to each other. There are a lot of places for drugs to block protein synthesis, and that's why you have different categories. So let me take you on a little tour through some of these groups. Here's the sulfa drug group. I've already mentioned metabolic analogs, and here is that description that I just took you through about them trying to make folic acid. And at the top left structure here, you see PABA, para-aminobenzoic acid. That's the precursor needed to make folic acid, which is we'll call it a vitamin for bacteria. To the right of it are three variations of sulfa drug synthetic chemicals. These are not naturally occurring chemicals. They're all synthetic. And notice that the basic structure of them look like PABA. So that, again, they are molecular decoys. The ones that impact nucleic acid synthesis, I've already mentioned Cipro. The brand names, by the way, are down at the bottom, just in case you know any of them. These are in the group of drugs called the quinolones. Very effective, broad spectrum, as are the sulfa drugs, by the way. There are some very bad side effects from the quinolones, though, by the way. Sulfa drugs, not that many side effects. Some people are allergic to them. The ones that block cell wall, again, the entire penicillin family. I want to point out to you on this picture, PenG. This was one of the original chemicals identified by Alexander Fleming. And I want you to notice two things. First of all, in blue, there is a four-sided part of the molecule, and that is called a lactam ring, a beta-lactam ring. And all of the family of penicillin, whether it's ampicillin, carbenicillin, methicillin, ticarcillin, any of them, they all have this basic structure with that beta-lactam ring. Now, the side chain that is in purple, this is the side chain of PENG. But if you cut that side chain off and you stick on a different side chain, you make ampicillin. It still has this beta-lactam ring and the rest of the molecule. All you've done is change the side chain. If you change the side chain again, you have methicillin. By the way, over 500 different variations in the penicillin family. Why would you want to do this? Well, if you look down the list, you'll see that some of the variations in the penicillin family are acid stable, and the pill can be taken orally. You cannot take PENG orally. It is unstable in acidity. Some of these penicillin derivatives are stable in heat, others are not. Some of them are more broad spectrum, like carbonicillin is broad spectrum and good against gram-positive and gram-negative, whereas PENG is much more delineated in a more focused gram-positive group. The reason I wanted to point out that beta-lactam ring is that some microorganisms can produce an enzyme which makes them resistant to this family, and those enzymes are called beta-lactamases, and they break that beta-lactam ring, in effect, in activating the drug. So here are some of the drugs that affect cell wall synthesis, and I will go on. The cousins to the PENs are the cephalethins. They also have a beta-lactam ring. You can see it in green. This is probably the biggest group of antibiotics that are given. There's a huge number of the cephalethins that have been developed. The protein synthesis inhibitors, again, a lot of different ones. All of the aminoglycoside group, which includes streptomycin and kanamycin, all the tetracyclines kill in the same way, and the macrolides like erythromycin kill in the same way. These tend to be broad spectrum. They do have quite a few side effects. Nerve deafness is one of them. Kidney damage is another one. I didn't mention anything about side effects of penicillin, of the penicillin family, because there aren't a whole lot of side effects. They're relatively benign chemicals. Now, there is a problem with allergies, but that's an idiosyncrasy of your immune system. That's not a true side effect. Other types of drugs. I mentioned the ones that hit cell membranes. Let me move over to the antivirals. Everything we've talked about so far have been antibacterials. So let's talk about some of these. You're looking at a viral replication cycle in a cell, and this happens to be HIV inside of a host cell. And you can see some of the locations where the viral replication cycle could be interrupted by certain types of drugs, which you see in colored boxes at the far right. Protease inhibitors, fusion inhibitors, and so on. And in fact, people on HIV cocktails or AIDS cocktails, which are combinations of at least 3 chemicals, usually combinations of different ones of these. Neuraminidase inhibitors for influenza, like Tamiflu, block the final release of flu virions from infected cells. Then last, there are a whole lot of medications that act as nucleotide analogs. Some of these may be used for hepatitis B. Some of them are used for herpes, like acyclovir is. So when the host cell is constructing new DNA or new RNA, depending on whether it's an RNA virus or a DNA virus, it will inadvertently use one of these other molecules that is a molecular decoy, and of course it cannot complete the viral replication cycle. Antifungals, the azoles, like fluconazole, clotrimazole, they're all in this family. Usually they're given for things like ringworm or candida infections, something like that. Very often they're just given topically on the skin. They're not put into the blood. Not many side effects, maybe a few. By the way, the antivirals on the previous page, particularly the nucleotide analogs, have a lot of side effects. Antiprotozoan, the quinine derivatives. Quinines and quinolones are related. And over here you see the formula of chloroquine, and hydroxychloroquine would be identical to it, but it's got a OH on it that you don't see here. And this has been mentioned quite often now as a potential drug for the SARS coronavirus 2 that causes COVID-19. It's still out about whether that will work well, but anyway, wanted to mention that. But these are used for plasmodium infections that cause malaria. They interfere with hemoglobin use by the protozoan. HGB is hemoglobin, my abbreviation. Very narrow spectrum of activity. There are some side effects from them, one of which is neurological. You can stop here if you want to look at them. I'm going to go on. So, antibiotic resistance, I've already mentioned it. The CDC has got a huge website on this if you want to find out more.
Nature, Mr. Allnut,
So
is what we are put in this world to rise
above. From here. I do want to point out something, though, that's rather interesting. Up at the top left, you see dosages of penicillin given in international units, IU, for gonorrhea. Now remember that penicillin only hit the market for the general population in about 1946, after World War II. In 1947, the amount of penicillin that would be given to get rid of a gonorrhea infection was 0.2 million international units. By 1959, it had increased by 3 times in order to get rid of the infection. By 1966, if you look at the dose from 1947 up to 1966, we've increased the dosage by about 12 times. Then in 1980, by almost 20 times, showing you the increased drug resistance of Neisseria gonorrhea. And now it's not given at all. Other drugs have taken over to treat it. This is interesting in that it just shows you how quickly microorganisms change and adapt and become resistant. This is just due to genetic variation. It's not like you give a person with a staph infection a drug and the staph decides to change. There was already variation in the different cells, some of them spontaneously resistant. So giving the drug that most of the population is sensitive to kills off the sensitive cells, but then allows the resistant bacteria to grow unchecked. Here are some bacteria that have been problems related to drug resistance, antibiotic resistance, in addition to a protozoan, a virus, and a fungus in the group. And of course there's, you already know, I'm sure, MRSA, methicillin-resistant Staph aureus. an abbreviation you should definitely know. So, already kind of introduced you to this already, how this develops. We have a population of bacteria here. The green cells are sensitive to a drug. The red ones, for some reason, spontaneously, due to a mutation perhaps, became resistant. They're normally kept in check by the susceptibles because it turns out that resistant bacteria don't grow as well, as fast as the susceptible ones do. But if you kill off a fair amount of the susceptibles, which are these X's, means dead, that now allows the resistant cells to start growing unchecked, and they become the dominant population. I've already mentioned mutations as a possible mechanism, but remember that bacteria can exchange plasmids via conjugation. Also, DNA from one cell can get into another cell by transformation, just going through the cell wall and membrane. And also viruses can carry these genes. So ways to decrease antibiotic resistance? Here's a list. By the way, let me make sure everybody understands this. When we're talking about drug resistance, in this case we are talking about antibiotics and synthetic and semi-synthetic drugs, that drug resistance. The drug resistance that I am talking about is the resistance of the bacterium or the protozoan or the fungus to the drug. I'm not talking about resistance of the person against the drug. That does not happen. So on this list you see pretty self-explanatory statements here. OTC means over-the-counter drugs, which in some countries you can just walk into a pharmacy and get. A problem of too many antibiotics in animal feeds, and some of those resistant bacteria that develop in animals can be transferred to humans. Rotation of drugs, taking some drugs off the market, which reduces the selection for drug-resistant bacteria. And to finish up, here are some of the things that we've talked about. Drug resistance, obviously, allergies, host toxicity. Let me jump down to the bottom. Prevention of natural acquired immunity. You would like the person's own immune system to respond and become stronger. So it is thought that it's not necessary to treat some infections that are self-limiting and that would go away on their own, like certain types of ear infections, bacterial ear infections, otitis media. Let the child's own immune system respond, which will help them the next time. Now, that leaves us with this normal flora infection, which I mentioned earlier, and I want to point out two things related that actually I've already mentioned. The picture up at the top right is a colonoscopy. You are looking at the colon of somebody, and I want to point out that the lining of the colon has these big red welts running through it. This is colitis. The person has an extreme diarrhea. This is not just, diarrhea for a day. This is diarrhea where you don't want to go out of the house, diarrhea where you have to use a diaper, that kind of diarrhea. And it turns out that this is colitis caused by your own normal flora in the gut, Clostridium difficile, or sometimes called C. diff. It's normally there. It normally does not cause a problem because it is kept in check in numbers. But if you're on a long-term antibiotic therapy, particularly clindamycin is known to be associated with it, but others also, it wipes out a lot of the other normal flora that are in the gut and allows Clostridium difficile to now overgrow. And I'd already mentioned fecal transplants. Well, here's where a fecal transplant comes in. The other one I want to mention is Candida albicans. So the picture at the bottom, a view you don't normally see unless you're a gynecologist, you are looking through the vagina up towards the cervix. The woman is having a pelvic exam. And this white material that's all over the cervix and all over the walls of the vagina is Candida albicans, the yeast. So this is vaginitis that you are looking at. Why do women get vaginitis? One of the main reasons is they are put on an antibiotic. And very often that antibiotic is given for a urinary tract infection, maybe caused by E. coli. So the E. coli is eliminated and the UTI goes away, but during that use of the antibiotic, normal flora in the vagina was affected, and now Candida, which may have been a normal flora organism in the vagina already, but it was kept in check, now overgrows. This is just a look at cases of C. diff colitis, and it just shows you that this is an age-related infection. That is it.